start our evening. Led by Dr. George Smerdon. He is the chair of trustees for Palliative Care Works as a charity here in UK. He is a retired GP who has served here in UK and many parts of the world, especially in Africa. He has been supporting palliative care teams and programs and palliative care education in different countries like Zambia, Ethiopia, and in many different countries with his team. And indeed, it is quite a privilege to have him on board because they've got plenty of educational resources that we can learn from when we can just check their website. Together with him in the same session, we will have Dr. Gillian. Dr. Gillian is the professional social worker. He's the specialist palliative care social worker. And his thesis was actually focusing on the experience of the children who have got their parents having life-limiting conditions. And indeed, she has extensive work in Africa, in different parts of the world, like Tanzania, Kenya, Ghana, Ethiopia, and Palestine. So we have got people with a wealth of experience in this field, as well as always trying to explore ways and impacting the participants on how best to communicate the challenging subject that we normally find ourselves having to share. And I think in this juncture, I can just say we will have that the presentation which they will both deliver. And then after that, we will have the group discussion, followed by the video clip that will be demonstrating how the conversation can flow and what are the things to take into consideration. And because the world here as social and healthcare professionals, time and again, we communicated these things with the parents or with their patients and their families, and just to see how the dynamics will be. And also to learn about the strategy that can really help us to be organized in our communication, the Spike model. And it's just, if you have got a notebook and a pen, that will be incredible, despite the fact that we'll have for the recording later on. But anything that might really resonates with your workplace or things that you think they are very significant to your area of work, then it will be a good thing to note them. And then the session will flow. It will depend on the number of faculty members that we have on board. And we might have for the breakout rooms just to have for some other group discussions that are following the video that will be played. And after that, I think it will all come back to the main room, have for some few discussions and the summary of our day. But it is an incredible opportunity that we can all gather in one place and share this knowledge. I don't know, Erin, if you might say a couple of words before.
No, we're just really excited that you guys are back. You guys are keen students. You're showing up on time or early. It's very exciting. And please do reach out to the faculty. We have 11 today, Tebello, on the call with us, which is great. Wonderful. We have people that are working in the region. We have people that are interested in the region. And we obviously have people with a lot of experience. And our group within Palchase and Starlight and APCA is very non-hierarchical, if that's a proper word. So please just side message them on Zoom and reach out to them if you have a specific question. We want this to be as interactive as possible. And of course, we're not with you, which I think many of us would want to be with you in person. But yeah, so please do reach out if there's something that was said. Do that. And yeah, I think we should be able to do breakout rooms if our faculty are able to stay with us for the full hour and a half. It will just be random again. So our faculty will get some new students, but I'm sure George and Gillian will help us just with a few questions to go over or things to think of during our discussion time. So with that, I think Tebello, we can pass it over to Dr. George and Dr. Gillian.
Yes, indeed. Yeah.
Okay, shall I start? Can you all hear me all right?
Yes.
Good, fine. Okay, so hello everyone. I'm Gillian Chowns. I wasn't able to be with you on the first session last week, but I'm really pleased to be here and joining you today. And I'm particularly delighted that there are so many social workers on the group. That's a real thrill for me. I'm the only social worker in the Palliative Care Works team, and I hope that we can make the case today for the importance of multidisciplinary, multi-professional teams. I worked for many years in social services in the UK, and then I moved into palliative care, mainly working with children and families. And my research, as Tebello said, was with children, was participative research with children whose parents were seriously ill or dying. Tebello talked about the number of countries that I and George have worked in, so I won't say any more than that, except I'm hoping to be able to be face-to-face in Lesotho at some point in the near future. George.
Hello, everybody. I'm very pleased to be here and pleased to have met so many of you last week. Yes, I won't go over my biographical details, but it's a great pleasure and privilege for us to be part of the faculty working with Erin and Mo Tebello and with you all today. I'm very excited about the iEcho program and look forward to sharing experiences, learning from you all, as well as delivering some teaching. Today, as Tebello said, we're going to be looking at communication skills in palliative care, as well as helping you to explore some of the culturally sensitive issues around death and dying. Now, I know many of you are already experienced communicating very effectively with your patients and their families and your colleagues in your everyday jobs. But in palliative care, you will be aware that particular skills are needed to support patients and their families, to help with difficult decision-making, as well as sharing bad and distressing news. And not being able to save the lives of our patients needs to be confronted. This is either because treatments fail or because people come seeking help at a late stage in their illness, or indeed both. All of this places a great strain on everyone. I'm sure that you're very well aware of that. Our patients, their families and their carers, and us, their professional support, and not forgetting, of course, our own personal experiences. Now, this professional communication is a skill, and like any skill, can be taught, but must also be practiced. And you will understand in real life, we often struggle to get it right. So today we're going to start with a short presentation on communication skills, which for some of you may well be a revision. So hopefully it will generate lots of talking points, especially around areas you find challenging in communicating with patients living with and dying from life-limiting illnesses. And we really want this to be as interactive as possible. We've also been asked to look at breaking bad news, something we all find challenging. Then, as Tebello has said, we'll be showing you a short film we at Palliative Care Works made during the pandemic lockdown, looking at a family conference at the end of the life of a family member. And we'll talk about this later. This will be followed by exploring in groups in breakout rooms some of the issues raised by the film. You have experiences of your own, so again, please do share them. They're so valuable. And we're very grateful to Tebello for facilitating the discussions and to other faculty members for supporting the discussion groups. So over to you, Gillian, for our first slide.
Thanks, George. Okay, so if we can take the next slide, please. Thank you. I guess this comes up every time, isn't it? And we just are very appreciative of all the collaboration that is going on in this way. It's so important to work together. And that's the key message, I think, for palliative care teams, to work together. So for this session, these are the learning objectives, and I'll give you just a moment to look at them. So, as we've acknowledged, communication is the bedrock. It is the foundation of palliative care. So I'm pleased that we're exploring this right at the beginning of this course. Inevitably, there's always a great deal to cover, and as always in palliative care, there is never enough time. So we do urge you to look over the session and to try and deal with this and explore the topics in your own time as well. But 5 key objectives for this session, and you'll see that's important. We'll talk a little bit more about that. But we need to be culturally sensitive in order to recognise what is going on for others and what social context is. The phrase humble curiosity just reminds us that we can learn as well as to share and to teach. And then towards the end, we're going to look at actually 2 models. We'll look at spikes in detail and another one called break news as a way of helping us to deliver bad news effectively and compassionately. Now, if we could have the next slide, please. I'm sure that as George has done good communication for many years, so much of this will be a reminder, but we'll all have had experiences, both within work and in social settings, where we think that we've communicated something clearly, and then we realize that the person listening has not understood. So sending is not sufficient. It just is not enough. The message has to be received and understood for communication to really, really happen. So it's always 2-way, and checking out what has been understood is essential. Next slide, please. A reminder about why communication is so important, and it creates good relationships. Good communication creates good relationships. And relationships are key in palliative care when people are very vulnerable. It reduces isolation and uncertainty. And as we'll emphasize later on, communication enables us to both gather information and to give information, mostly in that particular order. Overall, if we communicate effectively, the other person feels valued, they feel understood. And good communication allows an expression of feelings. We may know the facts, but feelings for people are also facts. So there needs to be space for those. George.
Let's look at some of these things in more detail. Could we have the next slide, please? Just click on the whole slide. That's great. Thanks very much indeed. So we're going to look at empathy, the ability to understand and show feelings. And I'm sure that you all show great empathy in your work. But have a look at these 5 points and see if you recognize the components you personally feel comfortable and confident about, and others that you think you need to work on. You may feel you're a good listener, but can you show that you really understand what your patient is going through? And how about giving appropriate support when needed? The notion of being yourself, sharing how you feel with patients. Self-awareness is so important in communication. It's always, can I do better? And this concept of humble curiosity, what is it that I can learn from you? This includes acknowledging and respecting cultures, traditions, and belief systems, particularly important to patients and their relatives around dying, death, grieving, and bereavement. And I'm hoping that we can discuss this more and learn from each other. Could I have the next slide, please? So this is about diversity awareness, and this slide expands on the theme of awareness in communicating not only with our patients and their families, but also with each other as health and social care providers. It's important to try and understand how diversity impacts on health and social care, particularly in palliative care. How age, gender, class, sexuality, the patient's level of education, their religious beliefs, and indeed all these aspects of diversity can affect the way our patients deal with life-limiting illness. And I'm very grateful to Dr. Hassan for the quote, "Healthcare providers should be trained in cultural competence so that they can communicate effectively with patients from diverse backgrounds." So acknowledging and celebrating diversity, though, can be difficult for some societies and indeed for some individuals. And how we encourage our patients to share their life experiences, including their beliefs, concerns, and vulnerability, is an important skill, especially in palliative care. Again, we'd be keen to hear your thoughts. Could I have the next slide, please? Now, this is to remind you, and remind us all actually, how little we need to say and how much we need to use non-verbal skills when we're communicating with patients, especially so in palliative care. So what we do say, therefore, this 7% of the message that we orally communicate in words, what we do say needs to be clear and in language our patients understand. Now, the non-verbal components that are well known to you, I'm sure. The skill is how best to use them and adapt them to the benefit of individual patients. So this is about active listening and, again, self-awareness, how you sit by your patient or crouch at the bedside, facial expressions, the tone of your voice, nods and encouraging phrases, and indeed the use of silence. This is all about enabling and encouraging your patient to tell their story, and how much body language encourages and facilitates this. There's that lovely phrase, know your patient. And we'll talk more about this shortly. Now, whilst we were thinking about this, I don't know if any of you have used recordings of yourselves to study your communication skills as part of training or CPD. And we can learn so much from watching ourselves. So if you get the chance, please do so, but do it with colleagues who are experienced in using these for teaching purposes. Now, you notice that we emphasize culturally appropriate when we're talking about body language. Be sensitive and check with your patient, particularly around touch, asking if it's okay to do this. As you reach out to a distressed patient, a gentle hand on the arm or shoulder can be really comforting, but not if it's inappropriate. Gillian.
Thank you. Could we have the next slide, please? Thank you. So that's a nice quote there, I think, on the right-hand side from Maya Angelou. How we make people feel is absolutely crucial. And if we're going to be thoughtful and compassionate and effective, we need to be self-aware. That means we need to perceive and understand the things that make us who we are, the things that we value, what our personality is like, what our values are, what our beliefs are, how we express our emotions, the biases that we hold that we're sometimes not very aware of, and the judgments we may be quick to make. So it's really important to have that self-awareness and not to discount them, but to hold them to one side, as it were, because others that we work with will see life differently. We don't have to change or deny our values, but we shouldn't impose them on others. So for a very simple example, some of us show our emotions quite readily, others of us are more reserved. It's not for those of us who are free with our emotions to make a judgment about those who are more reserved, to think that they are not upset or they don't have strong feelings. So we just need to be really careful and be aware of our own values. Next slide for George, please.
Thanks, Gillian. Now, some of this will be a recap, but try imagining being with the patient now. How will I use my skills, knowing that conversations with patients in palliative care will often be emotional, distressing, and challenging? We've seen how important active listening skills are for effective patient-centered care. And if you listen well, your patient will almost always tell you all you need to know. the 80-20% rule. Paying attention and not interrupting, beware doctors, shows your patient that you care, that you value what they are telling you. It builds trust. Silence is an active listening skill and gives time for the patient to think about what to say next, and indeed to begin to experience some of their feelings. Never be judgmental. Allowing a person to voice their concerns and fears can bring great relief and help them to feel less isolated. A patient will often pause before they share something important or painful. And as an extension of good listening skills, you need to develop the ability to reflect words and feelings back to the patient and to clarify you have understood them correctly. An example could be, you seem quite angry, or what I'm hearing you say is that you don't feel your children are being very supportive. Is that correct? And using open questions encourages the patient to share their thoughts and feelings and adds clarity if you're not sure about something. And then throughout the conversation, check where you are. Summarize as and when you feel it's important and helpful by sharing thoughts, so that when you come to next steps and the sharing, decision-making and planning is more comfortable. Thank you, Gillian.
Okay, next slide, please. We're going to move on now to a particular aspect of communication, breaking bad news. So there's a definition of it. Bad news has been defined as any information likely to alter drastically a patient's view of his or her future. It's anything that changes their view of the future for the worse. We classically think of a cancer diagnosis as bad news, and of course it is. But equally, when a patient is, for example, told to give up driving, that's bad news. When a partner is advised that maybe the patient's bed needs to be moved downstairs, that's bad news. When the child in a family is told that their dad will not be able to play football with them anymore, that's bad news. And they will grieve. George.
Next slide, please. Grief, that terrible sense of loss. It's natural and normal and unique to the individual. We've all experienced it and will many times in our lives. The distress of losing a loved one is devastating. And you will have seen grief triggering a range of powerful responses, physical, emotional, and spiritual. And these will often come out over a period of time. We talk about attachment. The more attached a person is, the greater the love, the greater the sense of loss, the stronger the grief. And attachments, as Gillian has pointed out, are both tangible, things that we can see and touch, like a person, a house, a car, a place, and intangible, for example, our ideas, our dreams, people's goals, people's expectations. I'm not sure if you're familiar with the term anticipatory grief, that sense of loss before an actual loss. It's often not acknowledged, talked about, or even understood. So maybe something to talk about in our groups, as it has real relevance to breaking bad news. And again, as Gillian has pointed out, of course, grief isn't only death-related. We grieve for the loss of health, of a friendship that has ended, or losing our job or an ambition. If people have had to leave their homes, there may also be grief for their past life, their culture and families left behind. And not forgetting the need to acknowledge the various rituals of grieving.
If we may. How we break the bad news really, really matters. This is a lovely quote from Butman, and it's absolutely true. And George and I have lost count of the number of families who can recall word for word, what the nurse or the doctor said, where it was said, and how badly it was done. It's burned on their memories. So Buckman is absolutely right. However, the good news is that we can learn to break bad news well. And while we recognise that attitudes and cultures vary, we can't discuss breaking bad news without considering the issue of truthfulness.
Next slide, please. And breaking bad news is about being honest, telling the truth. So why is it good to tell the truth? Well, it's to maintain trust. People usually cope better with the truth than with uncertainty, even if the truth is painful. And lying will always destroy trust. Reducing uncertainty helps with decisions about treatment and care. And you'll know that sometimes, and we see this sadly so often, with the distress of living with life-limiting illness, patients and their families will spend much time and money searching for treatments that are not going to help, because no one is brave enough to tell them that there is no cure for their illness. And preparing for the future might involve writing a will, planning a funeral, or doing something that a patient had always wanted to do before they die, something which they may not have done if they did not hear the truth. It also gives an opportunity to put things right if there's some unfinished business in someone's life. And for many people, the importance of exploring spiritual issues. Again, so good to talk to you and hear your thoughts on this. Could I have the next slide, please? So we come to actually how one might break bad news. This is always difficult, but we can learn to do it sensitively and compassionately, gently, but realistically and with honesty. It can make a devastating and distressing situation so much easier to cope with for patients and their families, as well as for ourselves as professionals. It needs practice, and again, we don't always do it as well we have hoped. And we all know what happens when it goes badly. So here's one model to look at, known as spikes. It was initially offered as a protocol for delivering bad news to cancer patients. And since then, it's been adopted more widely and is a useful framework for communicating difficult news to patients in a compassionate way. I know how important this is to you, and having the recording and the slides will help you to go over this again in your own time and with colleagues. So S is for setting, the setup. You might say, let's find somewhere quiet to talk. So be prepared. Think about what you want to say in advance, and you should, of course, have read the notes and have all the information you need about your patient. Try and find somewhere quiet, a time that suits everybody, where you won't be interrupted. It's easier said than done in a busy clinic or on the ward, noisy ward. Ideally, of course, in the comfort of patients' own homes. And those of you involved in home-based care, I'm sure would agree. But you understand the principle. Most important to check out how you're feeling and try and leave behind your own pressures. Then it may be helpful to have another colleague involved in your patient's care to be present. It's really helpful also if the patient has a relative with them. So you make the introductions, bearing in mind everyone is going to feel anxious. So active listening skills to the fore.
So we come to P for perception. What we mean by this is finding out what the patient and family think and think is happening. As I mentioned before, if at all possible, always gather information before you give information. So having some phrases ready to use is really important. What have you already been told about your illness? I've read all your notes carefully, but I'd really like to hear from you as to what's been happening. Phrases like this. Then you can work out what you're going to say and how you begin. And then the question of the invitation, inviting the patient to say what they want to know. Most patients want to know about their condition, but there are some who don't want to. That's a sort of coping mechanism, And you'll be able to judge that by the way the patient is reacting. That's challenging. But if your patient doesn't want to hear details at this particular time, you can offer to answer any questions later in the future or speak to their family or a friend. Important to go at their pace. And absolutely crucial to use language that is appropriate. It's particularly important, of course, when we're working with children. Phrases that are obvious to us may have quite a different understanding from children. Remember that it's two-way, so it's really important to check out what the patient and the family member is thinking. You do this, it saves confusion and ensures there is a common understanding. Then you can move on to knowledge.
Knowledge is about explaining the illness and care options in plain language, as Gillian has said. Warning the patient that you have bad news may reduce the shock. Sometimes we call it a warning shot, but it's about using phrases that signpost where the conversation is going. I have the results of your latest blood tests or a recent scan or x-ray. I'm afraid it shows that there is a serious problem we need to talk about. Or something like, it seems that the treatment you have been having is not working as well as we had hoped. And this signposting is so important. But for many people, hearing the clinicians say, let's go and find a quiet place to talk, can also signpost the bringing and the hearing of bad news. The patient and their friend or relative will need enough time to absorb the new knowledge and ask questions. They may be very emotional. There may be many questions which you may not be able to answer. So be honest. If you don't know, say, I don't know, but I will try and find out. And give the patient information about what can be done to try and help and when they will be seen next. Above all, reassure the patient of ongoing support. This will help them to cope and feel less isolated. Gillian.
And George mentioned emotion there, and that's about respecting feelings, responding with empathy and allowing emotion to be expressed. It's important that we don't make assumptions about what the patient might be feeling. In my research with children whose parents were seriously ill or dying, the young people were really clear that one phrase adults used made them really angry. I know how you feel. That's not for us to say. We shouldn't assume, but we should give them the opportunity to express their feelings. Facts are important, but feelings are equally so. So use active listening skills. Remember that all patients are different.
So at this point, it's helpful to try and summarize where you are with this discussion, understanding what's coming next. So it's important for all present to say something here by way of sharing their understanding, the patient always going first, and how you summarize can confirm the patient's understanding and is also an opportunity to clarify any misunderstandings, reflections. Encourage your patient to express their concerns and suggest that they and their relatives note down any questions they'd like to ask you at the next meeting, reassuring them that this is an ongoing conversation. Quite often when you're breaking bad news, it has to happen in stages. It's also important to remember that it may be therefore necessary to pause the discussion and come back to it later. Always check out how your patient is feeling and responding and go at their pace. Now, it's worth remembering that there aren't many absolute rules in palliative care, but one is never say there's nothing more we can do. The mantra of palliative care is there is always something that can be done. Now, you will know that it will not always go as smoothly or as you would want. So remember, it's good practice to share with a colleague how breaking bad news went and how it has left you feeling afterwards. So we do recommend that you go over spikes in your own time and share it and practice with colleagues. So as you feel a little more confident, when faced with this, you will have this in your skill set. And now Gillian is going to mention another model that we at PCW have developed that appears in our PCW toolkit? Gillian.
Yes, I'm just going to very briefly talk about break news. If we could have the next slide, please. I'm conscious that we are running out of time. It's always such a challenge. And you'll see that this is very similar in many ways to Spike. So I'm not going to go over it in detail. It's one that we use regularly, but as far as you're concerned, you need to choose one you feel comfortable with, and then to adapt it. Remember to adapt it to the individual and to the situation. It won't feel genuine if you just do it by rote. It needs to be adapted. So the one thing I really want to just comment on before we close is this last one, stop and reflect, and reiterate what George was just saying about the importance of discussing it with a colleague, or at least giving yourself some time. We always need to recognize the impact of breaking bad news. Breaking bad news is not easy for others to hear. It's not easy for us to do. So accept that it's hard, that it's exhausting, that you did your best, even if there are still things that you can learn and improve on another time. You may not have time to stop straight away after a visit, but try and find some time before the day ends to reflect. You're not Superwoman, and you shouldn't try to be. Tebello and Joan both have talked about self-care last week. None of us can afford to neglect it. So S is for stop. And that's what I'm going to do now and hand back to Tebello.
What a wonderful and informative session indeed. The one that resonates so much with most of us, because communication is the web that connects us as human beings. Even animals do have their own language of communication. It is the fundamental thing and a crucial element of how we connect, how we build relationships, how we assess and identify issues, how we solve the problem, how we negotiate. Indeed, the critical thing to remember, even as we are a collaborative a group of organizations and people to discuss, we were communicating. Even relationships, the partnerships and the collaborations, or contracts can never come to place without people communicating and connecting. And organizations, they just come along as logo and a name, but it has to start with communication between human beings, heart to heart, mind to mind, and soul to soul. And what an incredible session you have delivered, Dr. Gillian and Dr. George. We are very, very much privileged with this wealth of knowledge and wisdom that you have shared with us. And I just hope our colleagues and participants will be able to really see how they can apply to their individual situations. I think now, with regards to time, we will be heading to the video at 7:50 Lesotho time. But for now, I think it's best that we can just allow people to ask questions, to have some general discussions in this bigger group. The smaller groups will be after the video session. Thank you.
There's
Anyone with a hand? Okay.
There's a really great question in the chat. Maybe I'll pass it to George. How do you stop yourself from being emotional when you break bad news? For example, crying.
Yes, it's very difficult. I think we all understand that, and I have cried with patients in my time, and I think I probably will do again. It's a balance to be struck. I think the important thing, you are there for the patient. So if you are feeling emotional, it's important that you are saying, it's not about me, it's about my patient and about the relatives. So it's having that internal conversation that checks your own emotion, says, stop, hang on, this isn't about me, this is about you, it's about my patient. And I think it's that awareness that you're in a situation where you know you're going to be emotional, so you kind of build into that an early warning system, if you like, that says, if and when I get emotional, I will remind myself that this is not about me, this is about my patient and what they are going through. It comes back to this notion of empathy. Is that helpful?
Thank you very much, Dr. George. And another thing, you have touched base on self-care. Sometimes we enter into conversations that are so much identical to the situations we are experiencing in our own lives. Sometimes we have to be honest and genuine with ourselves. If you are to enter into a conversation that is actually provoking you to enter into a certain level of emotions within yourself, and you don't think you are ready that day, not necessarily that you are not fit to do the conversation, but you just feel this one might be a bit too much for me just for today in this journey that I'm in. So it's just to communicate with your colleagues and allow them to take that caseload for you. Any more questions?
Sorry, Tebello, can I
Gillian.
just come in there?
Yeah.
Thank you. I'm just reminded of a colleague who worked in, a social work colleague who worked in accident and emergency, and she had a teenage son who had a motorbike. And when cases came in, a young man, a teenager who'd had a major accident on a motorbike and was not going to make it, she was clear, just as you say, Tebello, that that was not something that she could do. And she would ask another colleague. And that was not dipping out. That was not being weak. That was absolutely being very, very sensible. And if I can just go back to this question about emotion, absolutely with you, George, about what you said. I'm also reminded of a child in a family that I worked with who said to me that when she was visiting her dad in hospital and he was dying, and she was speaking to the nurse became emotional and a bit tearful. She said, I liked that because I knew the nurse cared about my dad and that helped me. So the nurse wasn't so hopeless, so much in floods of tears that she couldn't be of any use. But for the child, that demonstration of sympathy, of emotion, of caring was really, really important for her. So it is finding that balance always. Sorry.
I guess one thing you could do, of course, because we're also working in many different cultures, is we could ask the family if it would be okay for us to cry with them. Maybe in some cultures it isn't appropriate, so for a professional to cry. So I guess depending on how long you've been working with the family or relating to them, yeah, I mean, if you felt like it was appropriate to ask that question, we could also ask, would you be okay if during the next few days or however the relationship has gone, is it okay for me to cry? Maybe also helpful. I'm not sure how it works in Lesotho. Is someone, Dr. Hassan? I know you're not originally from Lesotho, but how does it work?
Okay, hi, colleagues and Erin, thanks for the good question. And the person who asked the question is very common in the setup where all of us, we work in a palliative care, Lepheane, and speaking truth, myself, I have wiped my eyes in front of the patient and the family quite a lot of time, and it's not something which is not improper to my thinking that yeah, as a human being, a practitioner, a palliative care practitioner can have that break. But I know with time you can control your emotion, being like the way Gillian and George just explained, that to self-talk, like self-counseling yourself, it will help. But if your tears come out, I have seen it comes out, you should not stop that tear. Rather, you can share that this is a part of empathy to me, that you are sharing the emotion, touching the patient and the families, that situation. Thank you very much.
We probably have time for one.
That, in detail. Okay,
Yeah.
sorry.
Go ahead, go Tebello.
Yeah, I just wanted to highlight that, as Dr. Hassan said, because we are all human beings, and that human emotion, when it comes, we can quickly try to center ourselves around by focusing back onto the patient so that they don't end up giving us counseling and comforting us when we are actually there to listen to them, quickly find our balance and go back to, asking, how do you feel? And, take the focus away from us. We are human beings and it does happen. Yeah, I think that is the only point I wanted to highlight. Yeah. Any more questions, maybe, before
There's
we get ready for the video?
There's some really good questions, Tebello. I know Tebello is multitasking, although I heard recently that we think we can multitask, but we really can't as humans. So there are tons of very good questions in the chat, and I think we should cover a few of them because these are really good. So I'm actually going to copy and paste them so we can also do them again in our group chats. But there's a really good one here about the letter P and how do I understand and uncover what a patient and family thinks is happening. How do we manage its perception? What do they understand of their illness? I think that's probably a skill we don't do so well.
Gillian?
Thank you, George. I would say, as one of my most helpful teachers said, talking in terms of talking to children, ask. So that question, that suggestion I made, when you can say, well, I have read all the notes, I've had discussions with my colleagues, but I'd really like to hear about what you think has been happening, is an invitation to the patient. And as George has said, if you stay silent for long enough, if you practice active listening, then the patient, the family will eventually say, there's a real art in being prepared to wait for that silence. And perhaps sometimes just to question, just to repeat a sentence. And I think you'll see this demonstrated in the film when somebody talks about how their wife has changed, how they're a bit different, they're more worried. And just to repeat, you said more worried? People will find it hard not to respond to that and to then to elaborate and to say what's really worrying them. And then there are some people who are so self-contained and so determined not to give anything away that you won't get anywhere. And it becomes a question, I think, of just waiting for the window just to open, just a tiny chink, and you might be able to get in. There are occasions when we aren't able, and those are hard to live with, but we can only do our best. George, do you want to add?
No, I think that's very fair. I think it is about asking, trying to help unlock the patient's own understanding of their condition, and I think one of the things that I feel very strongly about is that patients are so vulnerable coming into our territory. They have to learn a new language about illness and health, and sometimes by reducing our conversations to very much more simple language will unlock the patient's perception. But I think it's okay to say, what's your understanding about your illness? What have you been told before about why you're so sick? So I think, it's important to acknowledge that patients will have been given information already and that they're processing it, and it's important for us to know how they're processing it. Thanks, Gillian.
We
Can I
could
just
probably...
say, there was a very good question in the chat I noticed, was that I think it's a really important practical one. It's around how many people do you have present when you are breaking bad news? And I think for me, there's an interesting cultural issue here, because I've worked in places where everybody crowds in, and you try very hard to say, could we have a private moment perhaps with the patient and the husband or wife? Oh no, everybody has to be in. And it's how you negotiate across that cultural divide, if you like, for the purposes of breaking bad news over. So I'd be interested to know if there are experiences people have got about that.
Yeah, Annalise has just replied in the chat. She's working in a refugee camp in a fairly densely populated area in Kenya, and she said it's really difficult sometimes to have that privacy. So I guess in some settings, it is not only the family, but sometimes even the other patient's family listening in, which is obviously not ideal. But it's kind of the reality, I guess, sometimes. There's another
But I
really good
suppose
question.
the other thing is ask the patient, because if you say to the patient, look,
Yeah.
you know, is it okay if I ask your family to give us some privacy? And they say, no, I want everybody here. Then you're getting that clear direction from the patient. So, you know, as we've said throughout all of this, it's check with the patient what's right for them. We have to work around that. We have to work with the patient.
One of the advantages of having others in the room, other family members, etc., is that they then are also hearing the same words as the patient does. Because I'm sure we've all had experiences where the patient or the other family members relays what is said, or indeed, as I think Annalise was saying about translators, but it's not relayed exactly. People hear it differently. So there is an advantage in more people hearing exactly the same thing, even though they often then go on to interpret it slightly differently.
I was just highlighting the cultural perspective from Lesotho, in which case more often you will find that the patient, especially when their illness seems to be advancing and that they feel really helpless in how they're experiencing symptoms, they tend to really get this feeling of being, you know, helpless so much that they give away their power and their decision-making capacity. And they become so dependent that people make decisions for them, and they will just be coming into the room, the whole family, even the neighbors. So I believe the whole reason why this palliative care is so crucial and really important for us as Basotho now more than any other time is just to embrace the fact that palliative care starts from the point of diagnosis. And if we have journeyed with this patient when they came by themselves or with only one member of the family, we will have established the relationship, have spoken to them, and then even if then the information that has to be broken is a much serious one. Then we have established a rapport to really check with the patient, who would you want to be part of this conversation as you came today to collect your results? Then that might help us to strategize how to approach a big crowd that is waiting to enter the room with the patient, just to ask a few members that we will have had the consent from the patient, and then reassure the rest of them that with the discussion we are going to have, then the whole family will update you accordingly. But for this session, may we just have a moment with the patient and 1, 2, 3 people that the patient will have given us to ask into the room. Because otherwise the patient are always disempowered, but we need to empower them so that they know they are part of the journey. And the journey is about them, and we need to honor their own wishes and preferences.
Well said, Bella.
I think, Erin, you can go ahead with the video clip.
Yes.
Any more questions?
Yeah, there are some more questions. So faculty that are on the call, I know we have people from many different countries as faculty. Please do chime into the chat. There's some questions there about anticipatory grief, which may look very different in different cultures. So let me share my screen. We're going to have our video now for the next 12 minutes.
This video is about conducting a family conference around end-of-life issues. It's part of a series of training videos introducing you to 5 different aspects of palliative care. They've been created by Palliative Care Works, a charity in the UK that offers palliative care training overseas. For the trainer, there'll be points where you can stop the videos and discuss issues raised with your trainees. Accompanying the video is material which will assist you with your teaching. The videos and training material are all based on the Palliative Care Toolkit for resource-limited health settings. In this scenario, the social worker is holding a family conference with Yusuf, whose wife Asli is extremely ill, and their 2 adult children, Hassan, a successful businessman, and Khadija, who still lives with her parents and is caring for her sick mother.
Oh, good to see you. Thank you for coming. I'm sorry to keep you waiting.
It's all right. It's a shame, Yusuf, that Asli's not well enough to join us, but perhaps we should get started. Hassan's had a long journey to get here. We've got about 3/4 of an hour, and then I need to go and see another family. So
We don't need that long. It's perfectly obvious. My mother needs to get to hospital. They'll give her proper care and she'll get better.
Oh, so my care isn't good enough, huh? Well, how dare you? Turning up here at last, ordering us around. You haven't done anything these past months. Too busy being the big businessman.
Please, Hassan and Khadija, we mustn't quarrel like this.
I can see that you're all upset and worried about Asli, but it would help me if I heard from each of you in turn as to what it's been like these last 2 months since Asli got so ill. So Yusuf, could you start, please?
Asli's always been strong, so hardworking, and she never complains. And then she began to get so much more breathless and tired. She wouldn't say much, except that she told me not to worry and she didn't need to see a doctor.
Well, you should have insisted, Dad.
Khadija, we will hear from you in a minute, but we just need to let Yusuf finish.
Oh, there's not much else to say. You know, when we saw that first doctor at the hospital, he told us that it was her heart that was the problem. And he gave her some medicine and said, take her home and see how she goes. And I think she has got a little better. She had some soup yesterday.
Well, thank you, Yusuf. You've told me what's happened. Can you tell me how you're feeling?
Well, I'm very worried, of course. She's not the same, Asli, but God willing, she'll get better.
When you say not the same...
She doesn't seem much interested in anything anymore. She seems tense and anxious. She never used to get cross, maybe a bit impatient somehow, but I'm not criticising.
No, of course not, Yusuf. But that has helped me get a better picture. Hassan, now what's your sense of what's been happening?
I've told you, she needs to go to hospital. I can pay. I didn't realise how ill she was until I got here. It's not easy to leave the business. I do care about her. Khadija isn't the only one, even if she's always been the favourite. But you need someone to get a grip on things. You know, take control. We need to act now. The hospital will be able to get her better. And it's awful seeing her like this.
Yes, it's hard for children, however old they are, to see a parent so very ill. Khadija, can I ask you, you've been doing a lot of the daily care of your mother. How has it been for you?
I really want to look after her. She's my mother. She's always been there for me, and I want to be there for her now, however long it takes.
For as long as it takes?
I'm not stupid. Just because I'm younger and I didn't get the education that Hassan got doesn't mean I can't work things out. I see it every day. Dad, she's not eating. She asked me to take the soup that you gave her away. She just didn't want to disappoint you, but she can't drink at the moment. She's not getting better. But her breathing, her legs are more swollen. She's getting weaker. She's getting worse.
I'm wondering if Asli's asked any of you about her illness and what's happening to her.
Well, she did ask me once if I thought she'd get better, so I reassured her and said it would be all right soon.
That's not what she told me. She told me she's frightened and she doesn't think she is going to get better.
She was frightened. Frightened, that was her word. She said that.
She did, frightened, and she started to talk about how would Dad and I manage, and Hassan was so far away, and I soothed her and said everything would be all right. She needs to concentrate on getting stronger. I didn't know what to say.
She won't get stronger here at home. I'm not surprised that she's frightened. She needs to be in hospital. But you should have told me, Dad. You didn't say. Look, there's no time to waste. We need to get her into hospital. We can't lose time keeping Mother here at home. And you all know I'm happy to pay to be admitted to a private hospital. She'll get proper, full care and we'll get a clear diagnosis at last. That'll help.
Well, Hassan, you're right that a clear diagnosis would help. And I can share that with you all now, if you would like.
Yes, I think we do.
Look, there are a lot of things that have come out of what you've each said just now. Things that I think deserve fuller discussion. But one thing is very clear to me. Just how much each of you, in your own way, love your mother, try to protect her, and want to do the best for her. You obviously don't all agree as to what is the best thing, but I could hear, and I think you each could see, how much each of the others are hurting, how much you all want her to get better. So, we all start from the same place, wanting to do the best. And working out what is best depends on understanding exactly what is wrong, the diagnosis, and then how things will develop, the prognosis. In Yusuf, you're right. You're right in understanding that it's Asli's heart that is the problem. It's become very weak over the last few months, and you can see how much worse she is in the last few weeks. Her heart can't work properly anymore, which is why she's so breathless and her legs so swollen, despite all the drugs she's on. And I need to be honest with you, there is no other medical treatment that will make her heart strong again and make it work more effectively.
No, you're saying that you're giving up? There's nothing you can do? You can't. You can't let her die.
No, we're not giving up. But Hassan, there's no treatment that can prevent her dying. But there is always something we can do, and we will do all we can to keep her as comfortable as possible in the time she has left.
See, I was right. She hasn't got long, has she?
Oh, please don't say that, Khadija.
I think your father needs you, both of you. I can wait a bit. You go. I'm so sorry. I know that this is so hard to take in.
But the doctor said she'd get better.
Well, I had a conversation with the senior doctor yesterday, Dr. Walid, so that I could be clear in my own mind about it all and give you the correct information. Dr. Walid has seen the results and read the notes, and there is no doubt her heart is getting weaker all the time. I know, Hassan, that you hope that your mother could have a treatment that would cure her, and it's just wonderful, really, that you're prepared to pay whatever it would cost. That would be brilliant. But actually, Dr. Walid was clear that she is on all the correct treatment already.
But in hospital, she would really get good care with all the right medicines.
She would get very good care there. But we must remember how well Khadija has cared for her over these last few months. And perhaps we also need to think about what she wouldn't get in hospital.
She wouldn't get us, would she? No. I couldn't be there with her every day like I am now. Dad, you couldn't be with her and sit with her when you come home from work every evening.
If Asli's illness was not so advanced, it might be worth considering the benefits of a hospital admission. But as things are, the benefits of her being in her own home, surrounded by her family, and being cared for by people she knows and trusts, well, they outweigh any benefits there might be from going into hospital. Nevertheless, you do need to think about the burden that might fall on you from continuing to care for Asli at home. It would create considerable pressures.
It's not a burden. I don't feel any pressure. I really want to do it.
Well, I know you do. I know you do. And you've been the most wonderful support, Khadija.
And that's something that I've heard from your mother, how much she appreciates all that. Her family is so important to her. All of you are. And caring for Asli is something you can all do. But protecting her from the truth won't help. supporting her will. And the palliative care team are here to help and support you all. They can teach you about how best to position her, for example, so that Ashley may find it a little easier to breathe and also to take some food and drink. But that means there is a lot for the three of you to talk about. And there's a lot you need to say to her. The time you've left together, as Ashley's life draws to an end, is very precious, very special. I need to go now, and you need time to think and talk. I'd like to suggest I'll ring you tomorrow morning and we can discuss the practical ways our palliative care team can support all of you. Not just Ashley, but the three of you as well. And that will be for as long as you all want. Thank you.
As to the WhatsApp chat, we have just noticed that many people could not really get connected and couldn't see the video properly. When they see the video, the voice and wasn't really flowing for them to get it. So it was cutting and a bit slower. We are very much sorry about that, but we hope you have been able to capture the real message behind it and how the dynamics of the family could be addressed by somebody, whether it's the social worker or anyone that might be in that similar situation as a member of multidisciplinary team, communicating and sharing news with the family, and also building the rapport and ensuring that the family is on the same page. They can really support one another and come up with a plan that will best suit their situation and their family. So I'm not sure, Erin, if you have been able to see if we can go into breakout rooms and just to discuss the video. If we have been able to watch it. If not, probably we can bring up some of the questions that were not attended to in the chat, or any more that people might have before we would come back to the main room.
Yeah, if Gillian and George want to give maybe a 5-minute synopsis, then we can head into the rooms. We'll have about 15 or 20 minutes in the room. So Gillian, did you have a way you want to guide our conversation?
Okay, well, I'm really sorry about the bandwidth and the difficulty. Can I just say what we could do is send you the full script of the video, and perhaps that can be attached to the recording or sent to all the participants, so they would then have that. Let me just try and summarize this very quickly. So so the actual patient is too ill to join the family conference, so that's unfortunate, but the dad, the daughter and the son are there, and it becomes very clear very early on that they have very different views. The husband is hoping that his wife will get better. The son feels that he can just pay to get his mum in hospital, and that will sort everything out, a private hospital. The daughter, who's been looking after the mother, has a much more realistic view. So the three family members have different views. They're not, as we say, singing from the same hymn sheet. So one of the tasks of the social worker is to acknowledge each of their views, to remind them that there is something in common they all have, that they want the best for their mother, and then to help them all to see what the truth of the situation is. So to be clear about the diagnosis and then about the prognosis, and she tries to give them time to take this in, offers a plan in that she'll contact them the next morning when they've had time to think and reflect, and discuss the ways that they can help support the family. So that's, I mean, the video happens in 10 minutes. Very often to actually get to that sort of point may take several visits. And you will have realized, of course, that because this was done in lockdown, we couldn't use other people. We just had to use ourselves. We are middle-aged, white English people, but we've tried to create a scenario that probably applies to many resource-limited situations. Okay.
Thank you very much with that summary. At least it has made us have a bit of an idea of what we might have missed, but in a nutshell, that is the situation. So I think, Erin, you can go ahead with sorting out the breakout rooms, please.
Yes, let me just make sure each room will have about 5 or 6 people. So yeah, I hope you have a good conversation, and I'll bring you back when you're done. Thanks, everyone. Welcome back, everyone.
Thanks. Yeah.
Yeah.
Tebello, you finish us off.
Yeah, I think it's just to really appreciate each one of us that has made it to this point. We have really been informed of so many different challenges in terms of connecting to today's call. Many of the people that are still here have really reattempted more than 3, 4, 5 times, and we are grateful. It just shows that we are all working this journey, and we try to make it really come to pass. And we really thank the faculty members that were able to join us today. All the participants, we are grateful with the fruitful discussions that have gone on throughout all the opportunities we had, whether it's in the chat or in this general discussions or in the breakout rooms. But one thing that we really appreciate so much, Dr. Gillian and Dr. George, the wonderful and informative conversations you have laid daily in our, as we go on with all the other sessions, we will build on this challenge of changing our practice, our mindset, because for any change to happen, there has to be the mindset shift. And culturally in Lesotho, we don't normally communicate anything about death and dying. We try to avoid that subject as much as possible, but we are actually having this interesting discussions of the practitioners from all walks of their profession, who are very keen to really embrace this new concept and see how we can apply it in our own settings. Also embracing the multidisciplinary approach, that the conversation is not just for one person, but at the point of need, if there's a doctor or a pharmacist or social worker or a nurse at the time when the patient has that desire to know more, then we just need to consult their notes, have more information and their background to be able to address the question at hand in a more sensitive, culturally acceptable, compassionate way, but with all honesty, without selling an unrealistic hope. So I don't know if maybe in summary, there might be some few words that Dr. George and Gillian would want to say before you can say something, Erin, please.
Gillian? You're muted. Still muted. So whilst Gillian is unmuting, it's been a very, oh, Gillian, over to you.
Sorry, only to say that I know that we're short of time. We overran in our presentation, so apologies for that. But it's been great to be part of this session. It is such an important subject, and there's something that we can all learn all of the time, us included. Thanks for all your contributions.
Yes, and thank you from me as well. Thank you all very much indeed.
I think, Tebello, as we end today, maybe a challenge to those that are still hanging on to this call, maybe try one thing new in your communication this week. Today is a bit overwhelming, especially with what Tebello has shared, that this may be really different than what we're used to doing. So choose one thing that you would like to try, and maybe do it even with your family. Our families sometimes are the best people to practice on, because I think if you expect when you are in that setting to be able to do it with confidence and empathy as the way we've been taught, it isn't going to happen so easily. And definitely have colleagues with you. I think we didn't talk about that too much, but in a family meeting, it doesn't just have to be one healthcare professional with 10 family members and a patient. You can do it together with your colleagues so that when you are faced with a really challenging question or an ethical dilemma, you're not there by yourself. And definitely, this is my nursing heart. Document your family meetings. Document the communication that you make with a patient, because it's really helpful for your colleagues to be able to build on what you've already done. And sometimes we don't get a chance to talk to our colleagues. We're so busy. You had a really meaningful conversation. The patient disclosed to you that they understand a little bit more about what cancer means. Write that in their chart. I know we don't always have time to do that, but it's really helpful for the team, and especially your palliative care colleagues will love you if you write it in the chart, because then they'll be ready, a little bit more ready for their session with the patient. But thank you everyone so much. I don't know, Tebello, how to say goodbye, but we'll see you next week.
Honestly, honestly, and like you said, it's just to try something, just small steps at a time. To be honest, personally, this communication is the big thing dear to my heart, because without wasting your time, it affected me directly, and I know how it feels. Some of us in the groups, we have been sharing even how personally this subject is very dear to us, because I'm one of those that was told while standing at a nurse station that your mother is dead. If she was unwell, then we would say there was an anticipatory grief. I would have seen it coming. This is a car accident. So somebody that has just left my house an hour ago, then I come to A&E having heard that there's a car accident around the area where she was. Then if you come to that nurse station, you are asking, I've got these names, I'm just looking, I'm just checking if you have got such a patient here. Oh, just go around that corner, you'll find the body on the trolley. So I am so passionate about how sensitive we can be. You exercise the same compassion you would want to be exercised to you in any situation. The news, they don't have to be nice, but they have to be given in a sensitive and humanly way. So I'm just saying to my dear colleagues who are still here, let us go out there, do our best, as Erin said, practice small, we will get there with time. It can never be perfect, but it's just we have to start somewhere. So I'm grateful to have been part of this call, and indeed that we have all been together to share our journey together. Thank you very much. Erin, I think I'm done.